Um, so this is intended for healthcare professionals, and again, hopefully you're a healthcare professional, and here's some of the disclaimers for this particular presentation. And hopefully you know who we are by now, but if you don't know, there's a guy named Devinder Prasad, he's from Punjab. Samia Asmat, she dropped in from Cairo, and I happened to come on a bus from Detroit. And so I want to declare that I have these following conflicts of interest, and a list of the various pharmaceutical support that we've received over the years for Devinder, myself, and Samia. So we're going to talk about the epidemiology, the burden of disease. We're also going to talk about the controversies and challenges in the pathophysiology of the disease. And then we're going to talk about the targeted therapy and the adaptive immunity as a therapeutic target. So all of these three talks will be integrated. And then we're going to talk about what are the remaining unmet challenges. And as we have heard, there are many unmet challenges for vitiligo. So it's my charge to make sure that we keep this engaged and also try to stay on time. But if there's areas that we would like to cover, let's go ahead and do that. So let's talk about the epidemiology. Now, we've got Khalid Ezzeddine here in the audience, and it's nice to have him as a world expert in this area. And many of you are experts in this area, but one of the first questions is, what is vitiligo and how common is it? Now, this audience does not need to know what vitiligo looks like, but vitiligo has been present in our civilizations and humanity for thousands of years. It comes from the Latin word vitium, for blemish, and in the traditional Indian texts, hilas and philita were also terms. The pathogenesis is felt to involve autoreactive T cells that attack melanocytes throughout the body. And as you know, there's a distribution on the face, the perioral areas, the wrist and the elbows, and we've talked about those. There's two main types, and those types were decided by people in this audience, the segmental and non-segmental. And there's a very interesting presentation about a potential pathophysiology linking a arterial distribution and viral processes for segmental. But as we know, non-segmental is the majority of cases, about 85 to 90%. Now, like all good biologists, we often will categorize these into a different taxonomy, which breaks it further down. And these are important because as we get into better taxonomies, we can give prognosis information to our patients and also hopefully decide which treatment options are better. And so we know that the acrofacial is a little more challenging to treat. There's the focal, there's mucosal, there's the generalized, which we've talked about using systemic agents for, the universal endpoint that we hope one day we'll be able to stop from happening, and then this mixed variant that's been described recently where people start off as segmental and then evolve into non-segmental. So these are just some of the classifications. But taxonomy is important for a physician, it's important for our field, it's important for our scientists, because how do you use these molecular characteristics if you don't have the taxonomy straight? Vitiligo affects a variety of people. As we saw some of the statistics, 0.4 to 2%, but the range is even higher. The key genes implicated in the GWAS studies were mostly immune-based, but it does show that there is a higher rate of inheritance for patients with vitiligo. Both men and women seem to be equally affected, and all ethnicities are affected. Vitiligo tends to hit people at the very emotional, vulnerable parts of their lives, ages 10 to 30. Now, as many of you know, any age can be affected, but this graph kind of shows the distribution where most patients get vitiligo before the age of 30. What does that mean? It affects schooling, bullying, impact on work, impact on marital relationships. So it hits people right when they're developing into their lives. Now, the prevalence of vitiligo varies tremendously throughout the world, and the team pulled together the different prevalence estimates. I don't think that Finland has no cases of vitiligo, but they're probably not apparent. And it goes all the way up to 10% in India, the country we're in right now. But as you can tell, or maybe you couldn't tell, if you weren't paying attention to Khalid Ezzeddine's talk, we have a lot of work to do on the epidemiology. These ranges are not consistent with most human disease patterns. So something that all of us can contribute is to improve the epidemiology of this disease state.
So comes the second question.
Second question.
Yes? What about the comorbidities of vitiligo? Is vitiligo a separate skin disease or only cosmetic, as they say, or we can have some other systemic associations? Although being cosmetic does not make it not a serious disease. Right. But tell us about the comorbidities.
Yeah, well, I think that conversation happens all the time because payer groups, parents, society wants to know, well, if it's cosmetic, it's not serious. But as we know, it is serious, and I think your question is valid. So thank you. Are there any comorbidities? What do you think? Yes or no? Of course. Wow, emphatic. There's somebody in the audience who had a good lunch. Okay, so you're absolutely right. Autoimmune diseases are much more common in patients with vitiligo. As Samia, Asmat, and many of other people in this audience have described, there's a systemic component of this disease. There's autoimmune thyroiditis. I have many patients who were diagnosed with vitiligo 5-10 years later developed type 1 diabetes, Addison's disease, pernicious anemia, SLE, rheumatoid arthritis, inflammatory bowel disease. And then how many of you have that really difficult situation where the patient has vitiligo, then they develop thyroid disease, then they develop inflammatory bowel disease, and some also develop autoimmune neurologic diseases. One of the things we're finding out is that patients with vitiligo seem to have sensorineural hearing loss, and the percentages vary, but it's been described in multiple countries. There's also a normal tension glaucoma, and then, as many of us know, you can also have multiple comorbid dermatologic diseases. People are always taught vitiligo does not itch, unless, of course, you have atopic dermatitis. Vitiligo does not affect the hair, unless, of course, you have alopecia areata. And we were always taught that the Th1, Th17 axis is distinct, Th2. Well, unfortunately, the statistics don't match that up. 1.7 to 7% of people have psoriasis with vitiligo.
But we all know now that vitiligo is a burden. There is a large disease burden with vitiligo. But what are the factors that can increase this burden?
Well, there's narratives, which are very important. The stories that many of us have heard in this room, and our patient advocates who are just such beautiful people. Let's give a hand to our patient advocates. They're here today. Thank you for being here. Honestly, they've been to more lectures than most of the people in the rest of the audience, so you are becoming content experts if you're not already there. But they can tell you the impact of this disease. They wouldn't come all the way to India from the different countries that they come from, as well as our Indian hosts, if this wasn't bothering them. But the quality of life, the work that defines what happens in these stories in actual data, so that Ahmed Al-Isa can walk into his healthcare authorities and hopefully get consideration for this disease, well, it impacts women a little bit more than men. Darker skinned patients do have a higher burden of disease. Not to say that lighter skinned individuals are not bothered, but the burden is lower. When it's on the face, visible areas, on the hands, there's a greater burden of disease. And genital vitiligo is a thing. It affects people's intimacy, it affects their relationships, and sexual dysfunction is reported in up to 58% of patients. But vitiligo is also a disease that interfaces with our cultures and the society that we live in, plus our physiology. And so the cultural stigmata differs depending upon the culture that you come from. And the areas that seem to affect quality of life are listed on that massive slide on the right side. So those of you in the back who maybe want to read that or not, but it kind of goes into gender, age when you get vitiligo, your skin tone, comorbidities, and then the symptoms that you have. But also things that Khalid, Azadine, and others are trying to measure. What if you can't get a job because you have vitiligo? A couple of years ago we were here and we met with some of the directors of Infosys, and they actively had to tell people to hire people who had vitiligo. It was shocking that that had to become a policy of a major company here in India. Patient perception also affects it. So again, face, greater than hands, genitals seem to have their own unique disease state. And then when you have the concerns of your baseline cultural group, there's a greater impact. The psychosocial impact of vitiligo is something that is getting documented more effectively. But just look at this infographic. 71% of people who have the condition fear the spread of the disease. 57% felt shame, 55% had insecurity, and 55% reported sadness. The number of DSM criteria diagnosis, remember there's a threshold for these diagnoses, is higher: depressive symptoms, anxiety, behavioral impairment, and emotional impairment, even to the point of suicidality. I think all of us have stories or experiences where we have a patient who became suicidal once the diagnosis was made. We also have wonderful patients who are also resilient, but these numbers give you the story. But a lot of the quality of life builds up into this area. The risk of mental health diseases in individuals with vitiligo is much higher than the general population. 1 in 4 have depression. 1 in 7 have anxiety. In the recent Valiant study, using the PHQ-9 screening questionnaire, 55% of a 3,541 member database had symptoms of depression. But look at the numbers in India. 89% of the patients who came from India have developed validated questionnaire-specific depression. If that's not a wake-up call to regulators in Saudi Arabia, in Delhi, in Washington, D.C., I don't know what is. Because if you're becoming depressed, especially these younger years, it's going to have a tremendous impact. A majority of patients experience moderate to severe effects of vitiligo on their quality of life. And again, you can have this one story, well, this person has vitiligo, it's not bothering them. Well, that one person is that one person. And then you also have this person who's dramatically affected. But the quality of life allows you to tell the story of the entire population with one figure. And in this systematic review, you can see that the greater the surface area, the worse the quality of life. But it's not just a DLQI, which is one measure of quality of life. The Skindex, the Vitiqual, and the VIS-22 all state that you have a diminishment of quality of life. And what is it about science, the philosophy of science? If you see the same result from multiple perspectives, that's truth. Daily living, it's associated with a self-consciousness. People wear different clothing. You have these beautiful clothes in India, but individuals may not want to expose those areas. Socialization, we do know that patients with vitiligo have diminishment in their career objectives, in their timing and the ability to get married. And again, we talked about the sexual dysfunction. But also, vitiligo isn't just a disease of the individual, it affects the family. Even at this meeting, I've had a few family members come in and talk to me about their families and the impact of the disease on them. And these are caretakers. These are the people who love the individuals with vitiligo. In adolescence, imagine what happens then as far as the impact on that family, especially in cultures where vitiligo has a higher stigmata. Patient self-esteem lasts well beyond that period of adolescence, and it can extend to the adult caregivers. 26% of the caregivers have depression, 42% have anxiety. The family DLQI is moderate to high effect. And the dermatitis family impact score has a significantly reduced quality of life. So we can tell you the stories affecting everybody, but here's the data. You also have sensory symptoms and functional impairment of the skin. Sunburns occur in patients. Not all patients with vitiligo develop photosensitivity, but many do. And up to 35% of patients have itching. So vitiligo has psychosocial effects, it has systemic effects, it also has local effects. What about the economic effect?
So we can have the audience to share if they have any questions as regard this part of the epidemiology and disease burden.
Stephen?
It's funny about the sunburn. I'm void of color. No, thank you. I'm void of color, thinking that, okay, I'm there, I can live a normal life, I'm going to just move forward. Then I get sunburned, reminding me that I have this skin disease. Then I look in the mirror. I don't recognize that person. So there's always constant reminders every time I try to move forward to live a normal life. One step forward, two steps back. So this is going to be a chronic issue I'm going to take to the grave. But the good thing about what we're doing here is that we're educating people to own the disease so that you can control it, not let it control you.
He's from my hometown of Detroit. Stephen, thank you. I know we know you don't need a microphone, but thank you for that. That's my...
Sir, how about access to best treatment? How you can improve it?
Well, I think one thing
And
we're trying
at
to...
affordable cost, of course.
Affordable cost.
Yeah.
Devinder, do you want to handle that one? Maybe the next talk? I think that's a question that we're going to be asking, and one of the ways we're going to do it is addressing future clinical trials, making sure the trials are cost effective, but also getting the fundamental causes. But Dr. Prasad will be covering that in his next session, but don't let us forget that one, so we have to address it. And that's what's going on here. We don't even really know what the cost of vitiligo are. Out-of-pocket expenses are listed over here. It's in excess of $10 million, but can you imagine that if 89% of a population of maybe millions of people have depression, you can't assume that the mental health cost is only $10 million. It's so bad that I pulled the phototherapy codes for phototherapy in the United States, and just using the code for vitiligo, it exceeded $100 million. And the data from the Medicare claims is 49 million, so the data isn't even accurate. The willingness to pay. 78% of patients in this small study are willing to spend more than 10%, more money than they spend on rent and food to treat and cure the vitiligo. So we really have to get these numbers to be improved. We need to get all of you data so that you can go back and talk to your regulators and your society to try to improve coverage for this. But the economic burden is poorly defined. But there's a spectrum of acceptance. There's that story that I think Khalid talked about earlier. A young Pakistani male in the United Kingdom came into the clinic and he wanted to know how to amputate his arm because he has vitiligo. And I can tell you from other South Asian countries that we see that happen. But we also have about 30% of our population in the United States who don't want treatment. And that's also part of the spectrum.